welcome to this exciting product launch event for HealthIQ. And also, happy International Women's Day. Congratulations to all the men to have us, right? Okay, my name is Satu Saxman. I actually have a slide showing my name. I'm the CEO and co-founder of a biotech health company called Nightingale Health. We are headquartered in Helsinki, Finland, and I will soon tell you why I am and why the company, why we are here in Singapore. First about my name. This always works in Singapore or in Southeast Asia. So it's the same as number one in Malay language. So this is the way how you remember my name in the future. This is like every second truck driver telling this joke to me. I'm like, yeah. Okay, so why we are here today? This is the explanation. So we're talking about preventative health. We are talking about how to make health screenings better, how to make people's life better, how to change chronic diseases to chronic health. Two companies, Innocus Diagnostic here in Singapore and Nightingale Health from Finland, we are in partnership bringing this product to the Singaporean market starting very soon. The name HealthIQ comes from the partnering companies. So Nightingale Health and Innocus makes HealthIQ. This is now how you remember this name as well. Okay. But that's about me and about the topic for the event. Now I think it's time to open the stage for the great speakers that we have today. First one, let me introduce you, Chris first. So, opening speech will be given by Dr. Chris Ting, co-founder and vice chairman of Pathology Asia Holdings, a leading clinical laboratory diagnostic network spanning over Southeast Asia and Australia. Here in Singapore, Innocus Diagnostic is a part of Pathology Asia. Chris was a clinician in Australia and then pursued his MBA and became an entrepreneur and investor with 28-year track in the healthcare industry. Chris has a passion for medical technology and data science and is currently a director or founder at a number of healthcare and medtech companies. His career has also included roles at the Singapore Economic Development Board, where he contributed to initiatives aimed at advancing the nation's biomedical sector. With a vision to leverage economies of scale and technological innovation, he's committed to enhance access, reducing costs, and elevating healthcare quality for the communities Pathology Asia serves. Welcome, Chris.
Thank you, Satu. I've got a few years ahead of Satu, so I like her. I need speaking notes, and my memory is not as good as hers. So, welcome everyone, and good afternoon. Thank you everyone for being here for this launch of HealthIQ. First of all, I want to say thanks to Satu and to Teemu, our partners at Nightingale Health. They've been fantastic collaborators in this journey, and I'm excited to hear Teemu speak later as well. And we're really excited that you have chosen us as your partners to roll this out across Singapore and the region. Secondly, just a quick thank you also to Jeremy Lim, Dr. Jeremy Lim, who's our invited speaker and our panelist. Always full of wisdom. So looking forward to your words of wisdom later on. And finally, to my team at Innovative Diagnostics and Pathology Asia, thanks for your dedication and hard work to get us to this point and to make this day possible. Thanks very much. I think, I need notes. So today I'm not going to talk so much specifically about HealthIQ because we've got more qualified and more learned people than myself to talk specifically about it. What I wanted to do today actually is to spend a little bit of time talking about the role of diagnostics in clinical medicine. And I want to come from it from a perspective of sort of managing labs over the last 30 years, including from the perspective as a doctor, a carer, a patient, and also a payer. So if you'll indulge me, let me begin with the humble lab test. So not all of you might know this, but I know we've got health economists in this room as well. But lab diagnostic spend accounts for about 2 to 3% of total healthcare spend, right? Depending on the country you look at. But we know that it influences up to 70% of medical decisions. That's right, 70%. And just to put that in context, right? In contrast, pharmaceutical spend globally accounts for about 15 to 20% of total healthcare spend. So that's about a 5 to 10 times increase in spending over lab diagnostics, right? So just hold that number in your mind as I continue. Lab diagnostics, right, even though it's relatively small in terms of expenditure relative to the other areas of healthcare, has a huge impact across the entire care continuum, right? So whether that's in preventive medicine and primary care, which we know HealthIQ will talk a lot about later today and its impact in that area, but also in aiding diagnosis, also in treatment selection, in treatment monitoring, in guiding prognosis, right across the care continuum, diagnostics plays a major role, right? And so it's arguable that from a, price to performance or cost to performance ratio, this tool in healthcare, right? There's no other tool like that in medicine. So, from my personal perspective, and my view is that lab diagnostics and diagnostics potentially in general, right, is actually grossly underutilized in healthcare. And for a moment, I'm not suggesting that there aren't wastage in the system, that there aren't tests that are being over-ordered every day, and I'm definitely not suggesting that we go down the route of Brian Johnson and do what he's doing, right? But I think for sure there are a lot of tests that should be done that is not being done today. Now, historically, the paradigm around lab diagnostics has been to view it as a tool for healthcare professionals to use it to aid them for clinical decision making. Right? That's been the traditional way we view diagnostics in general. But this ignores a very important point, and that there is another utility for tests in general, and that is, it is a very powerful tool to change behavior. And what I'm talking about is patient behavior. Ultimately, right, as doctors and health professionals, the end goal is to improve patient outcomes. That's all what we are trying to do, right? We have to make the real, where the rubber meets the road, is did the patient get better all the time? And we know all this, all of us know this, right? The most comprehensive, the most detailed management plan that a doctor draws up, right, is not going to work if the patient doesn't play their part. So at InnoQuest Diagnostics, we have a philosophy. We aim to be at the bleeding edge of diagnostics. Pun intended. But in all seriousness, we are all about giving healthcare professionals the information that is insightful and actionable, so that you can be more effective as doctors, right, as healthcare professionals. And internally within the company, we often talk about building the lab of the future. And what that means for us, right, is to come up with practical innovation innovation that actually gets into clinical practice in a very useful way. Because some things are too expensive, some things, are too cumbersome, inconvenient, etc. So what we want to do is to bring tools that are practical in the clinical practice environment. And this is where I think, as the later speakers will talk about, where HealthIQ will come in. So, HealthIQ not only gives you deeper actionable insights, it's also about keeping patients stay engaged, right, in their healthcare journey, so that ultimately they have a higher probability of adhering to your management plans and therefore achieving those better health outcomes in the long run. When I was in medical school, and I'm sure a lot of the doctors in this room would say the same thing, there was this doctrine that was imbued in us, and it was certainly ingrained in me. And it goes like this, right? Only order a test if you will change your management of the patient. So as a young doctor, I adhered to this blindly, right, without thinking about it. But 30 years on, as a carer, as a patient, as a doctor, as a payer, I think this rule, at the risk of heresy, because I know there are public health specialists here, I think that rule needs a major rethink, right? Because, and the context in which that rule is stated, right? Because as sound as that advice sounds, right, as I was saying earlier, it forgets that there is another person in that equation, right? It's not just about what the doctor will do. It's about what the patient is going to do, right? And I think we underestimate this tool that for behavior change that tests could potentially provide. I want to give you some statistics, right? In its 2003 report on medication adherence, the WHO noted, and I quote verbatim, increasing the effectiveness of adherence interventions may have a far greater impact on the health of the population than any improvement in specific medical treatments. Let me hit you with a few more numbers. Globally, up to 50% of medications for chronic conditions are not taken as directed. In the US, it's estimated that 300 billion USD is wasted annually, every year, on medications prescribed and not adhered to alone. So this is not even talking about stock going out of waste, etc. Just people not taking the meds when they're supposed to. In Singapore, local studies show that 1 in 2 to 1 in 3 patients, right, with chronic conditions don't adhere to their treatment plans. This is a staggering amount of waste, right? Not just of resources, but of a lost opportunity to help people get better. So the reality is this: tests don't just change what we do as doctors, they can also change what patients do. And that, my friends, I think is the opportunity I'm urging everyone here to think about. So remember the numbers I quoted earlier. So just like, as individuals or as consumers, we think about debt, right, as a force multiplier to improve our investment returns if we use it judiciously. I think there's a very strong argument to think about diagnostics in the same way. It's a relatively low cost in the healthcare system, but it can use judiciously. I'm not, again, advocating for unthoughtful use of it, right? Used judiciously, it has the ability to get us the twin outcomes of lower overall healthcare costs and better health outcomes for our people. I'm going to end by telling a little personal anecdote about my own journey as a patient. So if knowledge alone was sufficient to change behavior, then surely the phrase, physician heal thyself, would hold true. Well, since my late 20s, I probably had hypertension and hyperlipidemia, right? And let's say, even though I'm a doctor, fully knowing the consequences of the long-term effects of hypertension and high cholesterol, I wasn't a very compliant patient, right? So, but by the way, we've got doctors in this room. It doesn't help that you guys are a very demanding lot. It doesn't help with my blood pressure, but that's Thomas's problem. So back to my story. 10 years ago, I went to see my cardiologist, and he suggested that, well, your hypertension and your cholesterol has been patchy over the period, right? I think we should do a CT angiogram just to take a look at those coronary arteries, see how it's going. So I kind of said, oh, very expensive, you know, I want to go under the CT scan and be exposed to all this radiation. Anyway, he said, I think you should do a baseline. Lo and behold, seeing with my own eyes that 40% stenosis in the LAD, that was visually arresting. All right, that was a massive cardiac wake-up call. And you know, the truth is this, right? Post seeing those results, my cardiologist didn't really alter his management plan. Yeah, you know, come and see me a bit more frequently. Let's do the test a bit more often. You know, so the management plan itself didn't change, right? But what changed dramatically was my motivation and my behavior, right? And I can tell you today, right? It's still a struggle. I still forget to take my meds sometimes. I still don't exercise as much as I need to. I still don't eat like I need to. But I've always known what to do. That's never been a problem. It's staying the course, right? So obviously, you know, that's the story I wanted to share with you there is that, you know, we need to view, right, lab tests, imaging tests, whatever, you know, diagnostics, slightly in a different light, right? And that's really one of the key messages I wanted to share with you today. Okay. Let me see if I've got anything interesting else to say here. So in summary, I think, you know, there's asymmetrical power in the right diagnostics used at the right time in the right situation. It's not about the data for decision making, even though that's important. It's also about helping to create a narrative that patients can connect with and move the needle in behavior change. And that's what we believe HealthIQ could potentially do here. So it's not a panacea, right? It's not going to solve every adherence problem. It's not going to solve every risk stratification problem we have in medicine. But when used thoughtfully, it's another powerful tool you have in your arsenal. So I'm thrilled to introduce someone, next speaker. Sati, you happy for me to do it? Yeah. Dr. Jeremy Lin, he needs no introduction. I think everybody here knows him. He's a good friend. He's a public health guru, entrepreneur, founder of Amili, Southeast Asia's first and leading microbiome company. He's also an academic and an author. Most of you, or some of you, if you haven't read his book, you should read it, Myth or Magic, the Singapore Healthcare System. We're waiting for version 2, you know. So here's my good friend and someone whose insights I always value, Dr. Jeremy Lin.
A very good afternoon to all of you. As I watch all of you eat, sorry, let me offend people first and just get it out of the way. I was really struck, and maybe I can ask this question: how many of you are doctors? Doctors, put your hands up. Come on, don't be shy. I know many. I'm far more of you. So amongst the doctors, what is a soleus push-up? What is a soleus push-up? Very good. Yes, this is a soleus push-up. Why is it important when we discuss this after lunch? Because there is a very elegant study that was done that illustrates that if you do 1 minute of soleus push-ups, that's about 60 times in 1 minute, you reduce your blood sugar spike by about 50%, which is pretty good for 1 minute of work. Alright, but the fact that so few of us know this probably tells you that even fewer of our patients know this. Maybe one more question. What's the difference in mortality between people who spend most of their working hours standing up versus those sitting down? Okay, it's a JAMA paper 2021. Show of hands. Yes. What is the number? Okay. It's about 16%, and the cardiovascular difference in mortality is 34%. So it's all these little things that, quite embarrassingly, we don't tell patients, but the technology companies do. So for those of you who have an Apple Watch, you know that that damn thing vibrates every hour to encourage you to stand up. So there's actually really good science behind all of this. Then perhaps the question is, to what Chris alluded to, is the power of knowing, right? There's knowledge that when properly applied can be really very, very powerful, but we don't do a terribly good job of it. So, and I hear Chris loud and clear on the comment around the classic teaching, right? That we only order tests when it's going to change management. And I guess what I was asked to share some thoughts about was this topic from this quote from Hippocrates, where the greatest medicine of all is teaching people how not to need it. So, just some disclosures, I do a couple of things. I guess I'm here probably in Precision Public Health, NUS, or whatever capacity, but I only represent myself. So if I piss off any of you, I apologize, but please don't blame any of these organizations. And the reason why I do a lot of what I do is because healthcare is clearly broken and there is a better way. Okay, so many of you, this is Singapore today, right? Very familiar sights. This is Singapore in 1965. Okay, so elections coming, for those of you who are voting, I'm not standing for election, so I can say anything I want, okay? And interestingly, yes, I am doing a few of these Channel News Asia, Straits Times interviews to buffer my dear friends in the Ministry of Health when people ask why are healthcare costs going up, right? And I will not mention which senior civil servants have asked me to front it, but pretty much since I don't need to be elected, I can say many more things like, well, come on guys, look around you, we're aging dramatically. Look at obesity rates, hypertension rates, of course healthcare costs will go up. So, of course GST will have to go up, but no need to vote for me because I'm not standing for election. Okay, but the good thing is that we've had very, very impressive results in life expectancy, and truly, you know that Mr. Lee Kuan Yew wrote this book called From Third World to First, and he was describing Singapore economically and so on, but from a health point of view, we've been really impressive also. And you guys know that when anything is on Netflix, it must be true, right? Right, so this wonderful graph comes from a Netflix documentary that's called Live to 100, and Singapore was anointed a blue zone. Okay, that's complete bunkum, but sorry for another day. But what this chart is very, very powerful is showing that over the course of just a couple of decades, Singapore exceeded the US. We were about 15 odd years behind at the time in the 1950s. Now we're about 5 years ahead, right? So very, very impressive. We have done great things in terms of life expectancy. We have done not so great in healthy longevity. And that's also coincidentally, and maybe Nightingale Health and InnoQuest know something about the elections, but you know today the front page of the Straits Times is on the Ministry of Health budget, right? And again, the emphasis was essentially reinforced to all of us that Singaporeans, we have some of the longest life expectancy in the world, but we spend 10 years in relatively poor health. And how then do we narrow this? And that's really taking a very proactive systems approach. So the government does what it does, but we also as healthcare providers supporting our patients, we can also do our part, which is where tests like HealthIQ come in. The classic public health analogy is, which interestingly comes from Finland, all right? And I'm sure many of you have not been to North Korea. Have you? You have, right? Yes, okay. So anyway, story for another day, but the classic public health analogy is that of a person, the International Women's Day, cannot say man, so person pushing a cylinder up a slope. All right, the individual effort is important, but society determines the gradient of this slope, whether it's a 3-degree slope or a 30-degree slope. And what we want to do is to help our patients to make this gradient gentler and improve the intrinsic motivation of the individuals. And that's where, as the ecosystem, what we as doctors say really makes a big, big difference. Okay, many of you will be familiar with the 6 pillars of lifestyle medicine, but knowing is insufficient. Come, I've asked a couple of questions, nobody has given a good answer. Come on. humor me, what's the prevalence of smoking in Singapore? Wow, tolong lah, please. Okay, I will give $10. Right? Incentives matter, right? Wow, okay. Obviously, we doctors are too well paid. $10 doesn't move the needle. Okay. Well, I raise this because despite us knowing for over 70 years that smoking is associated with lung cancer and a whole host of other diseases, 1 in 8 people on this planet still smoke. So it is very clear to Chris' point that knowledge is necessary but insufficient, and we have to do more. We have to tailor the knowledge in ways that are meaningful to the individual. So I'll just whiz through some of the data around helping patients to change their behaviors and the potential impact. This is the diabetes prevention program that anyone who did not graduate in 1988 or earlier should know about it, because the diabetes prevention program was first published in 1992. Okay, data very, very compelling that lifestyle more effective than metformin in preventing diabetes in high-risk patients. And of course, 1 + 1 gives an even stronger effect. And what this Lancet paper shows is that at the 10-year mark, these lifestyle interventions persist. So for all of us who prescribe medicines, we can actually do a lot more than that. Clearly, the business models, the systems around social prescribing will have to evolve and improve. But let's not underplay how important patients' behaviors can be. And in fact, during the really pandemic, Kenneth Mark, who's our current DG, and I were on some panel like this, and the moderator asked Kenneth, what is the biggest thing that you've learned since the pandemic started? And Kenneth, to his credit, really great, humble guy, said, I'm stunned at how little we as the Ministry of Health understand citizens' behavior, right? And Tedros, who's the WHO really Director General, consistently reminded during the pandemic that we can make the world's greatest vaccine, but if citizens don't roll up their sleeves, and get vaccinated, all this is in vain. So behaviors really, really matter, and we can do a lot more in this space. And that's where tests improve the power of knowing. My diet is incredibly powerful. This is the Mind Diet, 7.5 years. In the spirit of true confessions, as what Chris shared, my mom is mildly demented. So diet and what she can do, what she can eat to live better, very, very dear, very personal, but the impact is tremendous, right? And how then do we do this? And how then do we help our patients be motivated to then do this? And then finally, I didn't want to nag you guys about the food we ate, because what's far more important is happiness and joy. This is the Harvard study that's now, I think, in year 86, and pretty much like what the slide shows, the most important thing, good relationships keep us healthier and happier. If you do nothing else, go home, kiss your partner, be happy. All right? These things are very, very important as part of overall behavior change, lifestyle management. Okay? I do write for the newspapers every now and then, but let me declare to everybody, I don't draw the cartoons. All right? I don't decide the headline, and this one I remember very much because it made me so many enemies amongst our own classmates, our own friends, because the Straits Times very naughtily put this cartoon up, and I know it's been used many, many times to illustrate how naughty we as doctors can be, all right? But there is a better way, and by helping our patients to live their best lives through technologies and really so on, we can earn a very respectable living, and our patients will then be motivated to continue to pay us because they get advice, they get very useful, healthier lives from us. And let's not be shy about earning a good living. We work hard, we deserve to have a good, or I wouldn't say good life, but a very decent life, and we can have it all. So if I just round off And the way that I see Health IQ is that it's really a health risk really assessment. Our entire healthcare system kicks in when people are sick, right? But there's a very long high risk period where we can intervene very meaningfully. And what I teach my own students in the NUS, in both the public health school as well as in the medical school, is to remember DISC, DISC, right? The key to co-managing, to getting patients on board as really co-pilots, is really we must provide data. They must see impact, all right? Relatively short term, and because my day job is running a little microbiome company, I always urge them to eat a bit more fiber, right? And it's amazing how much that improves symptoms of bloatedness, in IBS and all this, but the short-term impact, which may be subjective, is so important to getting them motivated to continue, right? Support is necessary, and that's where Healthcare SG comes in and some of the technological adjuncts, and finally, we need to build community. But if we can do all of this, we already have the other ingredients. We have the information, we have the data, and we as medical doctors are in that very, very privileged position that our patients trust us. So trust, data, can we do much more to help our patients live their best lives? I think the answer is yes. So thank you very much.
Thank you, Jeremy. Okay, the next speaker, we are getting closer to the actual topic of the day. So what is Health IQ? So the next speaker will be Teemu Suna, CEO and founder of Nightingale Health. I will let Teemu to tell about what really Nightingale is, but in a very short sentence, Nightingale has developed a blood testing technology that can, from one blood sample, detect risk of multiple chronic diseases. And Teemu will now tell how all this is possible. He is building the company in 10 years from a garage to publicly listed company, and taking this technology to multiple countries internationally. And then also to Teemu's credits, he has been my boss 10 years, so it's been a tough job. So welcome, Teemu.
Well, it's kind of tough to be number two because number one is here. So, all right. So very happy to be here, and thank you for the great talks by Chris and Jeremy. I think there is definitely, I fully agree, there is a way to have better healthcare. But to have better healthcare, we need technologies. I've been working with healthcare technologies for almost 20 years. The last, it's already more than 10 years. It's been with Nightingale, and I will walk you through how Nightingale's technology, what does it do? Why does it help to build a better healthcare system? I will go take a bit more detailed view today with the technology, go a bit through the science, and show you a bit of the background where we are coming from. So. We are working in preventative healthcare. When we started the company, we started with primary care. So the whole idea was not to go into specialized healthcare applications and do something super expensive and super fancy. The idea was to do something super valuable for everyone. The idea was to help solving the biggest healthcare challenge in the world, which are the chronic diseases. We operate all around the world, and the journey so far, like over the past 10 years, we have worked a lot with academia. Basically, I would say almost everywhere. So with academia, many academic institutions have utilized this technology to run their epidemiological studies. So that's how we have, that's how this technology is actually being already used all around the world. We run our laboratories, Finland, Japan, Singapore, UK, building up in the US. So we operate also in a very global scope. The technology is very broadly validated, more than 600 peer-reviewed publications. And the latest steps that we have taken over the past couple of years, we have actually rolled out the technology in nationwide clinical healthcare in Finland. So when we are looking at health screenings, when we talk about preventative healthcare, one thing that many times is not discussed probably enough. So what is the key ingredient to do preventative healthcare? Well, you need to detect the risks. You need to detect the risks of developing the diseases. So you need to screen, you need health screenings. And then if you can efficiently detect the early disease risks, then you can enable preventative healthcare. And this is exactly what we do. So if we go to our technology and we make a comparison between the current gold standard way of detecting risks, and we compare that to the way how Nightingale detects the risks. So in the current risk assessment, like for example, like Framingham score, we have the risk detection capability. We have of course good performance, but then we require several inputs. So we need blood pressure, we need family history, we may need some other questionnaires, we need BMI, so we need to collect clinical data points. We typically assess only one disease risk at a time. If the risk assessment is for cardiovascular disease, no other disease risks are being evaluated. So now if we put this in the very broad scope, like we are working in many nationwide projects. It takes a lot of resources. It's not very efficient to use these traditional tools to detect the risks, to run it for a large population. So now if we look how the Nightingale technology compares with the risk detection capability, we have equal or superior performance to the gold standard. The input we require, we only need one blood sample and age and sex. So this is very convenient also for the patient. So it's very easy to do because basically you need only the blood sample because age and sex you take anyway. Then the number of risks we assess, it's not a single disease risk assessment. We assess multiple disease risks at the same time, and we can do it from the same sample. So this leads to a technology that can efficiently screen for multiple disease risks just by utilizing the blood sample. And with this, we have already replaced many of the existing risk assessment tools in nationwide scope. So let's take a bit of a deeper look. Let's have only one disease here. Let's use the cardiovascular disease and Singapore modified Framingham score. So the current risk tool you need, age, sex, HDL, total cholesterol, blood pressure, smoking, family history, race. So you have a protocol where you need to collect the clinical data. With Nightingale, you only need the blood test, age, sex, and race. And this obviously makes it more straightforward for the clinician, but it's also more straightforward for the patient, which I think is also very, very important to get people to have the screening tests done. So what do we get? What can we get from a single test? We can get the risk for CVD, we have heart attack, stroke, type 2 diabetes, fatty liver disease, chronic kidney disease, and liver fibrosis and cirrhosis. So basically, many of the key chronic disease risks can be detected using this single blood test technology. So how can we do it? Is a question that we often get. So the difference with our approach in blood testing, we have developed this blood testing in-house. So this is proprietary biotechnology. So it's not a standard blood testing assay, it's something that we have created. That's why it has taken 10 years to build this up. So it's I would say it's quite difficult. So the difference is that instead of detecting individual blood values, we actually put the blood sample inside a high-frequency magnet. So we are using magnetic resonance spectroscopy, and because of this technology, we can detect a big amount of different molecules from the blood sample. And now when we can detect a big amount of molecules from the blood, we can understand the systemic biology much more comprehensively than just using the individual markers. And because of this, when we can capture the biology better, we can actually understand the risks for diseases better. And different diseases are reflected in biology in different pathways. So now if we looked at the different pathways in biology, and we have the diseases in the first column, and then we have the different groups of blood markers in the following columns. So we can actually see that if you want to really detect and understand the biology of different chronic diseases, you actually need to capture the systemic metabolism very broadly. So the diseases do not manifest with the same markers. And now when you have enough of these markers, you also can get a very holistic detection of different disease risks. So in more detailed level, here are some of the biomarkers that we detect by running this single sample. But this is why this technology is so powerful. It's just systems biology why we can capture the risks better. It's just systems biology why we don't need the clinical parameters, because we don't need the other proxies to understand the biology, because we actually can detect the blood values that reflect the disease risks. All right, let's have a very quick look at the scientific validation. This is also something we've been doing for a very long time. As mentioned, more than 600 peer-reviewed publications. So the data and the validation of this technology, it's all there, it's all in the public domain. I only have time for a very brief look at this topic, because when we look at the different population cohorts that have been analyzed with this technology, we have done this, as I showed in the world map all around the world, including also here in Southeast Asia. Maybe to highlight here, the UK Biobank is the world's largest health data repository. with 500,000 people. And there are actually 2 technologies have been utilized to run every blood sample in the UK Biobank. One is genetic technologies, so genome analysis, and the other one is Nightingale. Nothing else. And because of this, the Nightingale's technology has the scientific background that is next to none. When we put this into a timeline and we look how the scientific evidence has been building up over the past decade or a bit more, you can really see how the adoption of the Nightingale's technology in different scientific studies have really kicked off. And I think this is important because whenever you have if you have a single scientific publication, you can always ask, so what is the bias of the data collection that you had? Even in the very large population health data sets, you have a bias. But this technology has been actually replicated over multiple different biobanks and cohort studies. And you can see from the studies that the results repeat themselves. So it's not a bias that we detect when we are having the risk detection capability. It's actually biology that we are seeing because it replicates across the different studies. Here is one example from Nature Medicine. This paper utilizes the UK Biobank as a data source, but it replicates the findings across multiple different cohort studies. What the scientists were looking at, and this is completely independent, Nightingale has nothing to do with this publication. So this is done by international scientists led by a German group. And what they looked is that if you utilize the Nightingale's technology to detect the disease risks and you compare this against some of the clinical protocols, what is the performance of the SM? And the conclusion is that the performance is very good. And let's remember, we can detect the risks from a single sample. We don't need the clinical parameters. So what is then the clinical performance? Here we have, let's start with the comparison again to the Framingham score. And I think the relevant thing when we evaluate the performance is to look at the sample size. So the sample size with the Framingham score, we are talking like a group of 5,000 participants. This is the global standard used in healthcare. The data set in Framingham score, it's from the 70s, from a village of white male in the United States. It's a very limited data set in terms of the in terms of the diversity, in terms of size. So there are limitations. Now when we compare this to the Nightingale's risk models, our risk models have been built with more than 500,000 participants. And now if you look this from if you are statisticians and you look this from that point of view, the statistical power is completely different ballgame. And this is something that gives us like a very, very strong position for the risk detection and the capability of detect also the multiple disease risks. Of course, when you have more participants, your stratification improves significantly. So how does it then look like when we put the comparison using the area under the curve? So we take it a step towards like a more clinical performance comparison. So here we have the AUCs for the current clinical tools, and then you also see which tool is the comparison point. So we basically either we match the current tool or we are better in terms of the AUC. And again, one blood sample, age and sex, and you get this performance. And really, this is a technology that you can use to screen like entire populations, but of course, it's a tool being used in different health screening settings, because I mean, you get a more holistic view on the health risks of the patient routinely. And then when you detect the risks and you prescribe an intervention, you also can track the performance of the interventions, because the risks changes. When you take the follow-up test, the risk will change according to the intervention. And the nice thing is that because this does not include subjective data, there is no questionnaire data. This is objective tracking also, because we use the molecules, we use the blood, and the blood does not lie. All right, and then final part, benefits and clinical use cases. So one of the key benefits is that the risks are detected automatically. So the visual risk report is created automatically. So if there is no calculators that you would need to use, there is no manual data combination, you get the risks automatically. Then you get the assessment of the risks more comprehensively, and you can run it routinely. So you don't necessarily have to choose which disease risks to evaluate. It's basically tick in the box. And then a lot of manual work is, of course, saved. And I think it helps the GP, but I think this is also a benefit of the patient. And then we deliver also the absolute and relative risks. And I think relative risk, for example, in terms of the cardiovascular disease, which is heavily age dependent. So if you have a younger person, you can also, using the relative risk, you can show to a younger person what is the track that the person is already in his or her 30s. Because absolute risk is basically always low, but relative risk can be high, which helps to motivate the patient to a healthier track already in their 30s. As mentioned, this technology is already used nationwide in Finland. 30% of the Finland's workforce is being screened with this technology routinely, and what we basically did, we replaced the current, there is a version in Finland which is kind of a Framingham score for CVD, for example. We replaced the existing protocol with this. We replaced their lipid panel with this, because the biomarkers, the blood values we provide, you can directly replace the traditional clinical values. So they replaced basically their routine screening protocol for chronic diseases with this, and now we run it nationwide in the country. And we have here actually our customer from Finland. So they are the largest private healthcare provider, and in Finland, healthcare is very consolidated. So there is only basically like 3 big private healthcare providers, and the part of the system they are using Nightingale's technologies in occupational healthcare. And the Finnish system works in a way that companies are required to offer occupational healthcare to the employees, and then the government reimburses some of the testing that is being that is being offered. So it's part of the primary healthcare system in Finland. Ilse could not be here today, but we have a short video where she talks a bit about the how they use Nightingales.
Ladies and gentlemen, my name is Ilse Rauhaniemi. I'm a doctor and Chief Medical Officer of Preventive Healthcare at Terveystalo, one of the leading private healthcare providers in Europe. I am excited to share the incredible impact of the collaboration between Nightingale Health and Terveystalo. This partnership is a real-world demonstration of how Nightingale's multi-disease risk detection technology is transforming health checks and leading the way towards preventive healthcare. This cutting-edge technology has been launched in our occupational healthcare, which is a key part of the primary healthcare system in Finland. In its first year of operation, Terveystalo has already performed more than 100,000 health checks using Nightingale's technology. In addition, over 1,000 healthcare professionals now routinely use the technology in their clinical work. This innovative technology is making the work of healthcare professionals more efficient. By automating the detection of diseases, it allows doctors and nurses to focus more on patient care instead of manual data collection required by traditional risk assessment tools. This has not only improved the efficiency of healthcare professionals, but also brought significant benefits for our customers. Our health checks are now much more comprehensive, convenient, and cost-effective. The convenience of having a comprehensive, quick and easy health check means that more people are likely to participate in health checks more frequently. The collaboration between Nightingale and Terveystalo is an inspiring example of how technology can transform healthcare by bringing advanced multi-disease risk detection into our health checks. We can identify potential health problems earlier and motivate people to change their lifestyles. This is crucial in preventing the onset of chronic diseases and improving patient outcomes. Prevention is the future of healthcare. And Terveystalo, as one of the most advanced healthcare providers in Europe, is leading the way with Nightingale's cutting-edge technology. I invite all of you to take steps towards preventive healthcare for better outcomes and healthier lives for everyone. Thank you.
Thank you, Ilse. So now we are talking about the building blocks of first of all, the big picture and the reasoning and the building blocks behind the HealthIQ. Now I think it's time to actually talk about it. So the HealthIQ will be presented by Camille Cyncynatus. She's the head of product marketing and partnerships at Pathology Asia Holdings, the parent company of Diagnostic, where she focuses on integrating new technologies into clinical practice. So Camille is the best person to introduce the HealthIQ. Before you can come here to stage, please. Before that, I would like to also introduce the team of HealthIQ here today. So please raise your hand, all of you who are from IQ or from Nightingale, so that after this session, people can ask questions from you. And then also, we have prepared free of charge vouchers to try one of the HealthIQ tests. So if you are from a healthcare provider, Lily is there, and you can go and ask for the vouchers to after the event if you haven't yet got it.
Thank you very much, Teemu, for the introduction. You're going to have a little bit of a change of accent from the Finnish accent to the French accent. So it's good, we make you travel with HealthIQ. So thank you very much for allowing me to speak today. We just saw a video from Dr. Ilse in Terveystalo, Finland. That was, I think, a very compelling testimonial to how the Nightingale Health technology has really revolutionized the way she is doing health screening in her practice. And so I'm very excited today to introduce HealthIQ and to explain to you how this will also revolutionize the way you do health screening in Singapore and the way it will enable preventative health. So HealthIQ is a novel product line, and it provides a comprehensive understanding of chronic diseases. And what it provides, on the top of all the standard blood biomarkers and some unique blood biomarkers, it's up to 7 disease risk scores, which are listed here. So cardiovascular diseases, a risk score, heart attack, stroke, type 2 diabetes, chronic kidney disease, fatty liver disease, liver fibrosis and cirrhosis. And this technology is powered by Nightingale Health, and it's done in our InnoQuest laboratory in Singapore. It's a CE-IVD test in Finland, and it's a HSA-approved test in Singapore. Okay, so I'm going to repeat a little bit some of the things that Teemu said, but we believe that repetition is good to understand. So I'll go through some of the items already mentioned, but really the question here is, okay, but how is it better than the conventional screening methods? It outperforms traditional methods in 4 different ways. The first way, it impacts operational efficiency. How does it do that? And we're going to take again the Framingham risk score for cardiovascular diseases as an example. With Framingham, you will have to do all of that, right? Collect all those clinical parameters from the patient, and you can see that 3 out of those 6 clinical parameters are actually subjective, right? So they might not be correct. Smoking status, disease family and history, medical history are subjective data. Then you will need to have HDL cholesterol, total cholesterol, blood pressure. Then you will need to go in your calculator, input all those parameters, and that will give you your risk score. This is what's going to change with HealthIQ. 1 blood test, 3 clinical parameters, age, sex, and race, and risk scores are generated automatically, reports are generated automatically for you. And it's not only for cardiovascular diseases, it's for up to 7 risk scores. So, in conclusion, with existing methods, many data points need to be collected manually. Several tubes or specimens may be necessary. Multiple manual calculators are often required to transform those data points into risk scores. With HealthIQ, and I'm going to be fair on the both sides, with HealthIQ, the test using only 1 blood sample, only age and sex as clinical parameters, will generate those risk scores automatically, multi-disease risk scores automatically. The second way it outperforms the traditional method is by providing you with more consistent and superior risk scores. Back to what Teemu was saying, and maybe I'm going to add on a little bit more explanation about what is AUC, because maybe not everybody is familiar with it. So those risk scores by Nightingale have been, their performances have been assessed with the extensive data set that Teemu was talking about. And so the way it's expressed here in terms of performances is AUC, which is area under the curve. This is a metric that is used for diagnostic tests, which gives you the overall performance of the test. So instead of talking about sensitivity and specificity, it's one number that gives you the overall performance of the test. The closer this number is to 1, the better the test performs. So you can see here that for compared to the Framingham risk score, the HealthIQ test performed the same for cardiovascular diseases and myocardial infarction, but for all the other diseases, it outperforms the existing methodology, outperforms. So better risk scores in terms of performances. The other important aspect is the risks themselves, the consistency of the risks themselves. So with HealthIQ, you will have consistently for all the risk scores, 10 years risk scores, absolute and relative risk scores. And I'm going to spend a little bit more time explaining what are absolute and relative risk scores, because it's very important. So they differ, absolute and relative risk scores differ by the reference population that is taken to calculate those risk scores. For the absolute risk scores, the reference population is the entire population. For the relative risk scores, the reference population is the population with the same age group and sex as the patient. Why does this make a big difference? I'm going to go through this example. Okay. So this is a female, 45 years old, Chinese lady. She does the test. Her absolute risk score is 3.2%. What does that mean? It means that out of 100 people who had the same result, did the test, had the same result, the same risk factors, 3.2 went on and developed cardiovascular disease in the next 10 years. Relatively low risk. Well, she's also not very old, 45 years old. But if you look at the relative risk scores, how is this person performing compared to her peers? What do we see is that the trajectory is not good. She's not performing well. Her risk scores are much higher than the average of her risk of her group. In fact, her risk scores are higher than 95% of her peers. So the trajectory is not right. So here, for this lady, it would be time to implement some lifestyle changes. So this is the type of tool that we believe is going to change the way patients are consulted. It's very insightful information that both clinicians and patients should have. In the inverse, you can have a very fit 60-year-old man whose absolute risk score is going to be high because he's 60 years old, but he's very fit and has perfect lifestyle, so his relative risk scores are very low. Very important also for him to know that he's actually doing well. It's very encouraging, right? So in summary, with the existing method, every disease risk requires separate data point and calculators. The relative risks are rarely provided, and there is no 10-year risk scores for some of the diseases. With HealthIQ, you will have multi-disease 10-year risk scores, including relative risks. The risk scores are equal or better than with the existing methodologies, and it's using a validated algorithm using machine learning to generate those disease risks. Now, the third way in which HealthIQ is better than the existing methodology is that you have access to unique markers. And those markers give you insights into nutrition and systemic inflammation, which we know are linked to the prevention and management of chronic diseases. Nutritional biomarkers like fatty acids, so omega-3, omega-6, monosaturated, polyunsaturated, saturated fatty acids, amino acids, can give you an insight into potential dietary gaps that can be addressed with either dietary changes or supplementation, right? And glycoprotein acetylation, if you haven't heard of this biomarker, this is the single most potent biomarker to give you the level of systemic inflammation. And this we know is also linked to chronic diseases and aging. So with the existing method, you will not have all of those biomarkers. This is very unique to HealthIQ, and that will enable you to have a more comprehensive and proactive approach to disease prevention. The fourth way and last way in which HealthIQ is better than the existing methodology is that it is going to help you for your patient communication and motivation. So this is an example of the graphs. So there are 4 categories. The first one, you will have the ethnicity. Then you have the overall risk category, so low, elevated, or high risk. Then you have your absolute risk scores we talked about, your relative risk scores here. And they are designed, you can see they are color-coded, they are patient-centric, intuitive graphs that have been designed to engage and motivate patients to take proactive steps toward better health. And again, those graphs are automatically generated, unlike with existing methods where you sometimes don't have graphs, and in any case, you need to do it manually. So in summary, those are the 4 different ways in which we believe that HealthIQ is better than the existing methods. It impacts operational efficiency. It provides you with better risk scores, which are more consistent and more performant. It gives you very unique biomarkers that gives you insights into nutrition and systemic inflammation and aging. And it will improve your patient communication and motivation. And I think that's a slide that everybody is waiting for. The price! So we have 3 packages with HealthIQ. The risk package, which has the 7 risk scores. This package doesn't give you the breakdown of all the different biomarkers, so it only gives you the risk scores with the graphs. Sorry. Then the essential package, which has 3 risk scores, as well as other traditional and your common blood biomarkers. So your FBC, blood film, HbA1c, then you have the renal function, liver profile, lipid profile, and hsCRP and ferritin. Then your comprehensive package here is building on the essential package. It adds more advanced blood biomarkers compared to the essential one, and adds on more profiles, bone and joint, hormonal, infectious disease tumor markers, and the functional profiles that we just talked about, which is fatty acids, amino acids, and low-grade inflammation. So we have designed the HealthIQ product line to be modular so that you can customize your packages based on your needs. So you can choose any of those packages, risk, essential, or comprehensive, and add on modules, the HealthIQ modules. So here you can see if you have chosen the essential package, you can add on the 4 other risk scores that are not in the essential package. You can add on the functional profiles, special lipids, etc. If you do not have a HealthIQ package, you can also add on some of the HealthIQ modules. You can add on the 7 risk scores, you can add on the functional profile and the special lipids. For those modules where you can that you can order without the HealthIQ packages, you actually have a better price if you use the HealthIQ package. The reason is that by running the HealthIQ background, I mean the HealthIQ test, we do have cost savings that we want to transfer to you. So in summary, this is how HealthIQ is impacting the 3 main steps of preventive health, which is 1, identifying risk early by replacing routine single disease risk tests with multiple risk detection tests. Then, once you have identified your high-risk patient, use the result to target lifestyle and clinical guideline interventions. And thirdly, measure the outcome of those interventions. Repeat the test, track the progress, monitor. So this is the end of the presentation of HealthIQ. So we are going to launch the test March 17. So that it will be available for you to order. We will, I'm not sure, give you or given you already some vouchers to try the test. They are for internal staff, so they are not for patients yet. For patients, it will be only from March 17 onward. And we also have an early access program for you. So if that will be available for March 17, where with an essential package, you will have the 7 risk scores for free. With that, I thank you very much for your attention.
Thank you, Camille. So, I hope you found the presentation interesting, and we will have more to discuss then later. But before we end, we actually have still a panel discussion coming. I would like to invite to the stage Dr. Raymond Wang. Where is Raymond there? So Raymond has a couple of burning topics in his mind, and he would like to roast the speakers of today. So I also would like to ask Kristen, Jeremy, Camille, and Teemu on the stage.
Okay, thank you so much, Satu. So this is our final session. So if you do have any questions, please raise your hands, and our InnoQuest team will pass you the mic on it. So to get the ball rolling, maybe we can start with this question. So lifestyle has been a key factor. Can we pass one more additional mic to the panel? All right. Okay. So lifestyle has been a key aspect to prevent chronic diseases, but it is very challenging for many of the physicians or even for patients to keep up with them. Is there any silver bullets or tips that the panel would like to share with our audience today? Maybe Dr. Jeremy can go first.
Oh, very simple question. There are no silver bullets, I'm afraid. I think all of you know that also, that the data is very clear that the best time to change behavior is upon diagnosis of a health crisis. Like while you're being wheeled into the cardiac catheterization lab, they say, stop smoking. Right? The patients will say, Doc, I swear I'll never smoke again. But unfortunately, that by then a lot of damage has been done. And therefore, if we want to catch them proactively when they're pre-disease, meaning that they're at risk, that's when data matters. And I really like the relative risk, because patients don't understand risk profiles very well, but they understand how do I compare to my peers. And the relative risk scores done frequently allow us to be able to trend, right? And one of the frustrations with a lot of the testing is that it's not sensitive enough to detect meaningful changes. And then patients, after a while, they lose interest. And I think Chris shared a lot of data that the non-adherence to medications and so on really very, very high, because we're not able to sufficiently engage and motivate them.
Yeah, maybe to continue, I fully agree, and well, there is no silver bullet, but I think the good step forward is to make it personal. Basically, like what Jeremy said, basically the same thing, but if we make it personal, then we can help with that, we can help to build the motivation. And I think it's, if we come, when we look at the chronic disease, it is to detect the risk, but it's also the tracking. I think the tracking is also immensely valuable, because if you say, for example, if you say to patient, like, okay, let's try this lifestyle intervention, or like people many times, it's very hard to see the results if you look at the mirror and the scale. But then when you look from the blood, it may be that like you take a repeated testing in like 2 months, and you actually see from the blood the change. And this is the building the motivational loop. And I think all behavior is basically building the feedback loops that motivate to continue.
Yeah, I agree with the other two, and you know, while there's no magic bullet, I kind of sometimes have a little framework to think about. You know, when you've got a patient sitting in front of you, and you have two axes, right? And on the one axis, you've got motivation and behavior change, call it. And someone could have low motivation, high motivation is the axis. And then on the other axis, you have his risk, right? It could be low risk or high risk. And the reality is this, right? If someone's highly motivated and he's low risk, you do nothing. Like, he's gonna look after himself, right? If someone's high risk and poorly motivated, right? You've got to figure out, right, in your arsenal of tools, of which the test is one, all your different tests is one, your knowledge, you know, how do I move him across to one of these other squares, you know? And so to me, you know, you've got all these different tools, and there are others coming into the market, right? There are digital coaches that can help you nudge, you know. So I think you don't have to do it all yourself. And if you think about gaming apps and all that, right? A lot of us play games, but that positive feedback loop, right? You're trying to build habits, right? And so how do you give them a bit of a sugar hit, you know? So I do that for myself, actually. You know, I've deviated so much over the years, right? That was 10 years ago. I still sometimes don't take my meds, etc. Right? But then I do my blood test, and I say, oh shit, cholesterol's gone up again. You know, get back. You know, you do it frequently enough, right? It keeps you on that feedback loop. You know, but if you don't do it, it's easy to falter. So it's a continuous sort of journey, right? But I sort of like to use that framework, you know, and know that you've got this barrage of tools, right, available to you.
Okay, thank you so much. Following up to the questions, so there has been many developments over the years in technologies, omics and biologics that transform Singapore healthcare. In addition to this developing or promising AI tool or machine learning algorithm, how do you see Singapore healthcare will transform within the next 5 years?
Well, I think the money will get tighter. Okay, I will be quite upfront that all of us will need to be much more technologically enabled so that we are more productive. Right? I do also want to reinforce Teemu's point around personalization. And in my little startup, we're working with A-Star, using Nightingale technology to build on, and you'll see this in the newspapers in about 2 weeks' time. It's a major study that is called Remedy, where we take the Nightingale test, add it to continuous glucose monitoring, microbiome, food photo logging and all, so that we can then build out the personalization of the interventions. Because the data is very clear that if the 5 of us ate the same meal, the blood sugar response, the metabolic response will be very different. And as we build upon personalized risk assessment, we also want to offer personalized interventions. All of us give our patients fairly generic advice, and we know that eat less fried food, eat more green leafy vegetables, exercise more. It's not going to matter unless we can frame it in the context of what matters to the individuals. So we'll kick off this study next month. So hopefully in about a year's time, we'll be able to support everyone to be very personalized in terms of the intervention. Because it's funded by the government, the aspiration for us is to put an online tool that you can put in the Nightingale data and all, and some other parameters, and the algorithms will then spit out personalized recommendations, lifestyle behavior for all of your patients. So stay tuned.
Maybe I can comment about the technology side of things in healthcare. So it seems to be like in biotechnology especially, there is all the time something unbelievable coming, like with the omics technology, proteomics, transcriptomics, genomics. There's always kind of a huge promise coming up. But the thing is that you can have the world's, like you can have a technology that turns black to white. But how do you use it? What do you do with it? Like, I mean, there can be, like, there's always like big promises, but with technologies, it's just the first part is to create technology. The second part is how do you integrate it into the system? Because technology only creates the value when it creates the value to the one who is using it. technology in the lab is like, it can be great, but still it builds up no value. And now when you take this into the question that you asked, like how can we build, like how do we take this to like government level? So then your questions becomes like, okay, how can all the doctors, how they can use the technology? How can they benefit out of it in their daily work? So it gets quite complicated, and then you put like, there's been a lot of efforts around genetics. The problem with genetics is that it basically needs special training. It's not, you cannot track it. It's not trackable because it's like, the data doesn't change. So there's interesting technology, but you introduce a lot of problems. How do you use it in the real world? So I think this is very important point. A lot of AI and all of the tools, but what we need to think about is how does it create value for the real world?
And just as a subtext to that question, I think that hidden in that meaning, at least I read it that way, is that our doctor is going to be relevant tomorrow. I mean, my own view, again, is that all these genomics, proteomics, and all these other technologies that come is just another tool in your arsenal, right? And the value of the doctor, I think, will be maintained for, that's my view, right? Because it has that context that often all these technologies do not have. You've got a patient sitting in front of you. He's a 30-year-old Grab driver working 2 jobs, right? He's maybe looking after a kid who's got autism. His wife's the only homemaker. She's the one that cooks fried chicken every day, right? So you're telling him, eat quinoa, don't eat white rice. You're telling him, you need to be less stressful, don't work so long. That's not going to work, right? But you're the only one who knows what will work in that context for him, right? All the technologies in this world is not going to replace that doctor-patient relationship. And I think that's why that will persist. So I think all these technologies, yes, it's just another tool in your arsenal. But you know how to use it best, and I can't tell you, right? You have that in your power to use that tool.
Okay, thank you very much. I think I saw a hand just now. Anyone have questions? Okay. Yeah.
How do I feel a lot for like lifestyle and cardiovascular like a prediction, right? Or risk assessment. How about cancer? Are you all going into that area? Cancer prediction and
so I can answer from Nightingale's point of view. So we have looked a lot of different. We have in these biobanks we have a lot of like cancer outcomes. So we have run the data, and when it comes to the early cancer risk detection, we don't. Our models, that's not our strength, but I think that's an area that there are not very good solutions in general. It's a very complicated area, early cancer detection. What we are developing and potentially then bring to the market in the future is that when it comes to people who already have a cancer. So this technology is a good tool for prognosis. So we can look at the secondary tertiary prevention with this tool, but at the moment we don't have those. That part of the product is not in the market yet.
Just to add on here, so I guess you're talking about MSEV, multi-cancer early detection test. So we do have this test at InnoQuest, but this is not what we are addressing today with HealthIQ. But yes, those tests hold promises for the early detection of cancer, with all the caveats of constellation. If you do have a high risk and confirming this high risk, as this can be very early, even earlier before the detection of imaging. So it has its own complications and benefits, and happy to talk about it in more details with the test we carry at InnoQuest.
Next, do we have any more questions from the floor? Okay, in the interest of time, maybe this will be the last question. And to follow up from the previous question, maybe this is more for Mr. Teemu or Dr. Camille. how often should HealthIQ be done for our patient? And is there any inclusion or exclusion criteria before they should do this multi-risk assessment?
Yeah, well, I can start with the frequency. So when we look at how quickly the risks starts to change, it of course depends on the starting point, and it depends on the intervention. So I mean, if there is a very strict intervention and the starting point is not very good, you can see the results in like 2 months basically. But then how often you should be doing, like if you want to follow up the patient, depends again on the age group. But let's say that like in the normal situation, you may want to do like annual checkups to monitor the situation. If the patient already has a disease, then the interpretation needs to be done. And this is to Chris' point, that this is the clinician's work then to factor in that the patient already has a disease. For example, the person already has coronary artery disease, for example, and there is a lot of medication already, then the risks needs to be interpreted through those facts. But I think that's something that the clinician is doing to evaluate the situation.
I can just add here that we are not trying to change the way patients are going to be managed. We are just bringing a new tool that's going to help you identify this patient earlier. But you know, if you have a low risk patient or elevated risk or high risk, I'm sure you know how to manage them. We are not trying to change this. This is the point. So in terms of exclusion, I mean, there is no exclusion, but obviously it's a health screening product. So if you have a patient who has already been diagnosed with some of those diseases, maybe it's not the best product in that situation, and you might go on and do more advanced testing with this patient.
I think, Camille, I was going to say that it's not a either or. It's not a substitute, right? To me, it's a complementary test. So you can run it on its own. You can use it in combination with other things, and there will be situations where you might want to test once every 3 months, and there are situations where you might say once a year is enough. Going back to that risk motivation framework, right? And so there's no, single answer to that, but I think that's the way I view it. Yeah.
Okay, thank you so much for panel for the discussion. Now I'll pass the mic back to Satu.
Yeah. You just stay there. So I have some goodie bags for you, and then for the audience. So thank you so much for coming here this afternoon. I mean, it's Saturday, and a lot of competing programs. So thank you so much for coming. I hope you found the program interesting, and there will be more discussions coming on after this. So if you don't call us, we call you. So then the final thing, and do remember to take your vouchers from Lily. Lily went maybe outside already. But then we wanted to give you also speakers, a goodie bag. This is also for the audience, so do remember to take your goodie bag. And we want to walk the talk of the preventive health and lifestyle changes, and it's all about the small changes that you do in life. So this is a real goodie bag. So there are goodies inside. For example, I can show you from your bag, so that you know. So first of all, oatmeal from Finland. This is a very brick and mortar of the Finnish kids. I mean, I've grown up with eating this, but also for adults, it's actually rich in beta-glucan, and it's known for its cholesterol lowering benefits. So this is something that you should start eating in the mornings, increase for your LDL. And then you can top the oatmeal with the white blueberries. These are also from Finland. These are dried blueberries. What is the difference with these blueberries to the blueberries that you find in the grocery stores? the grocery store blueberries, at least here in Singapore, are like huge farm blueberries. They don't have much of taste. They come from Australia. They don't have much of taste. And the one very important thing is that they don't color your mouth. So when you eat these white blueberries, they actually color your mouth because they are rich in antioxidants and inflammatory compounds. This is the way how you see it. So when you eat this, go to see your tongue on a mirror because it will turn blue for a short while, not for. And then we also have prevention is the topic of today. So we have xylitol pastils. This is also something that Finnish kids are eating all the time. So this is something that you then eat with your oatmeal and blueberries. You have some sugars in your mouth, so this neutralizes the acidic attack in your against your teeth. So this is how you end your breakfast then. And then, since we are here in Singapore, where this is a sunny and warm country, I've been here now 1.5 years, coming from the north. Definitely something that you need to do. You need to protect your skin from aging. So this is a Finnish moisturizer with the sun protection factor 50. So then this after the breakfast, and then you are good to go rest of the day. Okay, so